So, antimicrobials, how we measure antimicrobial stewardship effectiveness has been a area of interest to us as we've kind of progressed through our stewardship journey at the vet school. And so we started working in this space when NCAS was first funded in 2015. And antimicrobial stewardship was really in its infancy in the veterinary profession then. And we were thinking about antimicrobial use. We were thinking about antimicrobial stewardship interventions and how we might evaluate those programs. And safe to say, there is a lot of different metrics out there for measuring antimicrobial use, for measuring antimicrobial resistance. And they're used in different settings. Some of them are used interchangeably, some of them are compared when comparisons are not very valid. And it makes it really difficult to pick one that is meaningful for consumers, for the prescribers, and for government and other global agencies that are interested in tracking antimicrobial use. But also that, and probably most importantly for us, we were interested in metrics that drive prescribers and drive farmers to prescribe more appropriately or to improve the way that they prescribe. And so some of the more common metrics that were being used were really, especially in the veterinary sector, were really around sales of antimicrobials, the gross tons of antimicrobials divided by some sort of estimate of the amount of animals in a population. But there was really very limited information about which drugs were being used by who and why. And that sort of really high level information was somewhat useful for governments reporting to WHO and WOA, but not all that useful for us on the ground. And definitely, using antimicrobial resistance as an outcome metric was even less useful. So we do have issues with antimicrobial resistance in some of our animal sectors in Australia, typically in equine and companion animals compared to livestock. And so it's a very insensitive marker of the appropriateness of antimicrobial use because it's so complex, so many different drivers of AMR, and also it takes a long time to change in response to antimicrobial use. And it also doesn't take into account the other harms that can come from antimicrobial use as well. So how should we measure antimicrobial stewardship effectiveness? I think there's some process measures and some outcome measures that we can think about. We can, in terms of the process measures, we can think about initiation and recording of antimicrobial indication, the selection of the drug, administration and monitoring. So looking at check-ins, when it was stopped, how long the duration was for, and then also disposal of antimicrobials. And then there's also some outcome metrics that we thought about as well in terms of clinical outcomes, so days in hospital, mortality, that sort of thing, some economic, so cost metrics, knowledge, and then also things like social license. And in terms of, so lots of different metrics there that we could consider. And there has been some work around what people mean by appropriate. And we kind of settled on appropriateness because it does it does drive better use of antimicrobials, and that's what we are really focused on, not just in the human sector, but in the animal sector as well, because we really recognise that antimicrobials are very important for animal health and welfare. They're very important for food security. So we know some work out of WOA that was just published in September this year did some modelling looking at the impact of antimicrobial resistance and climate change on food security, and found that particularly in low and middle income countries, the impact is going to be enormous over the next coming decades. So impacting available food consumption from animals by somewhere between 750,000 and 2 billion food for 2 billion people. So we really are focusing on appropriateness of use. So in this study in primary care, they when evaluating appropriateness, they said we should look at the indication, the choice, dose and duration. In hospitals, often it's a little bit more, it's been a bit more complicated, or more things included. So there's proven or probable infection, the spectrum is appropriate, allergy, we've heard about allergy already this morning, that there's no clear or obvious contraindication, and then route, dose and frequency, target site, and duration. So some common factors there as well. And then in this study, again in hospitals, they wanted a plan to be documented, susceptibility testing recorded, that the prescribing would be compliant with local guidelines, that an antibiotic stewardship program is in place, and allergy again. So, in every study, different factors were taken into account. And in animal health, appropriateness is really hasn't been used or assessed as a term. There is, obviously many different sectors in which antimicrobials are used, and many different drivers for antimicrobial use across these sectors. And so when we come to think about appropriateness, there's big differences between human primary care and aged care and hospital care. But probably the differences when we start to look at, a racehorse versus a chook in a shed like this versus a dairy cow out in a paddock. Once again, all the factors and drivers are going to be different again. Obviously a lot of the rhetoric has been around antimicrobial use, using less and less antimicrobial use for in animals, but we have to recognise that that does lead in intensive situations and non-intensive situations to increases in mortality in animals. And even though percentages might be small, the numbers can be very large. So that is definitely something that we need to consider as well. So in terms of measuring appropriate use, obviously in Australia, we're really lucky. We have the NAPS program, which does use appropriateness as the metric. And so there's lots of different streams in that now. And VetNAPS has been piloted, but there's lots of challenges associated with implementing that. So AMS is a One Health challenge. There's no point trying to tackle this issue in our own sectors. We really need to come together to address this. And so that was the basis for which we started this project. And I'm going to hand over to Ree, who's going to talk you through what we've done so far.
So as a result of all of that thinking, Laura and others prepared this early career researcher grant application to the Medical Research Future Fund, which was successful, and it's called COMET. We're hopefully constructing One Health metrics for evaluating antimicrobial stewardship. The chief investigators I've listed there, lots of familiar names to everyone from the NCAS space, but lots of also international collaborators and interstate collaborators as well. And thank you to those of you in the audience who've already helped with this project. the basic outline of what we're doing is, first of all, we wanted to know what does appropriate use mean to different stakeholders. I think we assume that people all basically agree on what that is, but as Laura has pointed out, there are major differences in how we deal with animals versus how we deal with humans. There are, for example, we would consider humane slaughter as an option to deal with an animal with an infection. This is not something that is considered in the human space. Also, sometimes people will say, well, why can't you treat all those, the animals that get an infection? Why can't you give them antibiotics individually? Well, I think you can imagine if you had to deal with an infection in that chicken shed that we just saw, really different kind of situation. Individually medicating that many chickens is just not possible. So we have to think about other ways of managing those things. So we ran some focus groups, which I'll talk about in a minute, with different stakeholders, some prescribers from both human and animal health, consumers, livestock managers, and policymakers. And we are then taking findings from that and from our literature review into an international One Health consensus process using the Delphi surveys, trying to define appropriate antimicrobial use and try to figure out how that should be measured. And for this, we're using AMS experts from around the world, again, from primary care, human hospital care, and animal health. And we're also involving people from low and middle income countries. I'm not sure if any of the Fleming Fund people are still here. Yes, they are. So we have already contacted the previous Fleming Fund fellows, and we'll be asking you to get involved as well, because we really want to understand what is appropriate in your contexts as well. So this will truly be a global One Health process. And then after that, we'll be following up with some focus groups to figure out what how the stakeholders interpret the consensus definition that we hopefully reach through this process. So the focus groups were really, really interesting. So the consumer focus groups, people had some understanding of some principles of AMS. I think we should be using them sparingly, only when required. And then one of my favourite things that people say all the time is that you must finish the course. That comes up so much in both veterinary and human spaces, and it's a really difficult one to take. Yeah, people were worried about that and taking the inappropriate dose. We had someone who said that their mother was given, whenever she gets a course of antibiotic tablets, she only takes half a tablet instead of the full tablet because she doesn't want to become resistant. So, and then others were really concerned about, I guess, the role of that doctor-patient communication when antibiotics are initiated, and that the same thing could be said in veterinary practice as well. The need to explain why an antibiotic is being prescribed, for how long they need to take it, and we know that's a problem more in the human side where whole packets are distributed, whereas in the vet side, in vet practices, we often give exactly the number of tablets that are required. So we didn't have a lot of issues with leftover antibiotics, well, probably fewer issues with that. But, it just having the consumer on board with the prescription and understanding why they are taking these tablets in the first place. So livestock managers were also fascinating. They, again, had this idea that we shouldn't be using antibiotics willy-nilly, so that's great. But then there were some interesting other things you can see down the bottom. Sometimes there's a money element. A farmer might see a calf puffing and go, oh, it might be pneumonia, but it might be a viral pneumonia. And they've gone and given antibiotics because as you can imagine, it's a bit of a different situation on a farm where a vet might come and visit every few months, and they know that they have problems at certain times of their production cycle, for example, calf pneumonia, and they might dispense antibiotics appropriately with a protocol of what to do when you see this happening in your calves. But sometimes they don't have those antibiotics in hand, or they have antibiotics in hand and they use them inappropriately. So that's a challenge. And then someone who had a lot of insight in that focus group said, correct dose rate, looking to avoid residues in the animal products, making sure that we don't go within the withholding period, which is the time that you shouldn't be giving the antibiotics prior to slaughter or prior to milking or prior to collecting the eggs. We have that to deal with as well. And there's an export slaughter interval as well, which is different. So those things are important to take into account with our global One Health process as well. Prescribers, I think we all know this quite well in this room. It's like, do we use antibiotics or not? That's the first level decision. And then, should we use them quickly if we think we've got sepsis? How narrow can we get that spectrum? What's the best route, dose, frequency, duration? How do we decide when to stop? And we had a pig industry prescriber, a pig vet, in that group who made the point that I made earlier about dealing with large volumes of animal, and you are doing population-based medicine in that context. So we're not talking about allergy delabeling or giving individuals anything. It's like we have to deal with this entire shed of pigs right now. So policymakers had reflected some of the same things as prescribers, saying right drug, right dose, right time, etc. Someone else mentioned, prescribing according to guidelines, which is a bit challenging in the vet space. We have some guidelines. There are species for whom there are no antibiotic guidelines whatsoever. So if you're dealing with a goat, you've got no guidelines. And in fact, we know very little about pharmacokinetics in goats. We know it's different, but it's a little bit of a grey area. And again, someone highlighted the population type dynamics that we're thinking about with livestock in particular. So this led us into our Delphi survey. I didn't know this, but the Delphi method was actually developed by this Rand Corporation in the 1950s in the States, and they did it to forecast the effect of technology on warfare. So it feels like it's quite far removed from what we're doing here, but we all know it's now used in many settings to hopefully get an expert consensus on things that are opinion-based or can't be empirically proven. And we get experts to answer multiple rounds of questions on a specific problem until we either reject an item and say we haven't got consensus on it, or we accept an item because we have consensus. And how you do that can vary. But part of the process is to provide feedback in each round on what happened in the previous round, and then allow people to adjust their responses. So what do we put in this Delphi? So we decided that we wanted to tackle this first and foremost about what belongs in an appropriate use definition in principle. We know that there will be issues around measuring some of these things, many of these things. We know that there will be even bigger issues in changing some of these things. But I guess we just wanted to start with what can we agree on belongs in that One Health definition. So who should get antibiotics? Under what circumstances? For what purpose? What does that appropriate initiation look like? What information should end users be given? How should people select drug group, dose frequency, etc.? And when is it okay to deviate from those principles? Which I think is an important question as well, because there are many situations that I'm sure we can all think of where, yes, in principle, you wouldn't normally do this, but because the patient lives 400 kilometres from the clinic, you might do something a little bit different to what you normally would do. So every Delphi survey that I've read seems to have its own quirks. You have to decide, what am I going to collect in terms of demographics? How am I going to do the Likert scales? What actually is agreement? How do we decide what is consensus? And you can draw that line in many different places. I've seen 50%, I've seen 95%. So that can really vary. What level of disagreement leads you to discard an item, and how do you manage those items that fall in between? So those are things we grappled with, and we had some extra quirks with our survey in that we are involving a really diverse group of people, high and low income countries, animal health who are focused on livestock, animal health people who are focused on companion animals and racehorses, that kind of population, human primary care, including dentistry, nursing, all sorts of situations there, and hospital care as well. And not to forget paediatric patients in those spaces. We recognised immediately that some of the more one healthy questions could be difficult for some of our experts to answer. So we had to have a strategy for that. And we ummed and ahed about whether we should include all antimicrobials or focus only on antibiotics. And in the end, we have included all antimicrobials. Whether we included topical application was also important. And we have just kept it all together. So, some of you will have already seen this because you've either piloted this for us or have received this to answer. But these are the kinds of questions that we're asking. So, for example, this is focusing on who should get antibiotics. And we're asking you, there was adequate evidence that the person or animal had an infection? You would reduce suffering or complications by using antimicrobials or reduce the contagiousness by using antimicrobials. And we settled upon this numeric scoring system, 0 not at all important to 6 extremely important. And you can see we've also given people that get out of jail card unable to rate. So we are also taking into account how many people say they can't rate an item. So we've also given people an opportunity after each matrix like this to give us some feedback. We recognise that we won't get it 100% perfect the first time round. So we're asking people, do you think we should change the wording? Did we forget something? So that's going to be really interesting. And I'm sorry I don't have any results I can share yet, but hopefully this time next year I'll have lots to share. So what we project will happen with the next survey round is that we'll be asking these same questions and then giving where people haven't already agreed with that, where we don't have consensus from round 1, we'll be asking people again, and we might report on something like this. We could say 75% of participants were able to provide a rating here, and the median score was 5 and the range was this, and here are some pertinent comments about the question. So, you know, that's just a made up example, but and then we'd ask people to rate that again in light of what they've seen from other participants. And then in subsequent rounds of this Delphi, we will be getting into that messy stuff about how feasible is it to measure this item, and how should appropriateness be classified? There are lots of different ways that people have done that. You know, you can be as simple as saying appropriate or not appropriate, but a lot of people favour a more nuanced system, and exactly how you develop that system is a bit tricky, but we will hopefully get to something useful by the end of this process. So I don't have any great answers to how we define AMS metrics across the animal and human health, but I would say watch this space because we're trying our best with it. And if you are an AMS expert in this room and you have not received an email from Kaz or Laura asking you to complete this survey, please email me because we really would love your participation in this study. That's it. Thank you.
Thank you, Laura and Ree, for your very informative presentation. I would like to invite our next speaker to come up. Dr. Lisa Guccione is a behavioural scientist and implementation science specialist based at the Peter MacCallum Cancer Centre. Her research primarily focuses on driving change in healthcare that delivers equitable, evidence-based practice to people with cancer, ultimately improving outcomes and experiences of these patients. Welcome, Lisa.
Thanks, everyone. Bit of a shift in pace now. So I guess my presentation is really about talking to you all about implementation science and how it's the key to enhancing efficiency and uptake of health interventions. So before I take a deep dive into that, I'd like to acknowledge the traditional custodians of the land in which we meet today and pay my respects to those elders past, present and emerging. Implementation science. So I'm sure everyone in this room is hearing more and more about implementation science. But what is it? Implementation science is the study of methods and strategies that promote that systematic uptake of evidence-based programs into routine practice. And it really focuses on understanding and addressing all those various factors that can have an impact on the successful adoption, implementation, and sustainability of the practices. And within the research and health community, we're starting to acknowledge more and more how important implementation science is, given that often healthcare interventions will fail to translate from research settings into clinical practice and change. So there's an estimated 17-year lag from bench to bedside, and sadly, approximately 85% of medical research falls into this theoretical concept of a valley of death, where basic research doesn't translate into practice. And what this means is that there's a significant amount of research waste, and this is estimated to be as big as $760 to $935 billion in the US alone. But most importantly, what this means is that we have a significant proportion of patients that then aren't receiving care that's appropriate for them. So what do we do? Well, a traditional approach usually involves this process where we see in practice that there's an implementation issue. We gather up all of our experts and key stakeholders, and we have this great brainstorming discussion about all the things that we could do. Someone decides on a solution, and then we implement it, and we just kind of hope that it works. But what actually happens is that often it doesn't. And when we're implementing this solution based on this concept of it seems like a good idea at the time, it doesn't usually work. And this is because implementation is difficult. And when we're wanting someone to do something different, it's a complex process that involves behaviour change. So when we're relying on intuition alone, it means that we may not have that clear understanding of what the barriers and enablers to change might be. And it also means that we may not be applying the methods that we need in order to change behaviour. So the field of implementation science really aims to bridge this research to practice gap by identifying what those effective ways to implement evidence-based interventions in real-world settings are, and drawing from those areas like psychology, sociology, healthcare, and public health to understand how best to do this. So before we develop solutions, we need to have that clear understanding what is and what isn't currently happening in practice, and how and why this might be different to what should be happening. What are the barriers and enablers? And what are the best solutions for bridging a research to practice gap? So implementation science really offers us those theories and framework that can provide that platform for us to do this. Allowing us to structure our implementation research on theoretical frameworks, develop theory-informed strategies for implementation, and enable us to understand why or why not interventions work, whilst also thinking about how we then take the next step to scaling these to more contexts and more populations. So there are three approaches that are really fundamental and foundational within implementation science. And the first is that process around describing what the issue is. The next one is around understanding and explaining all those factors that might influence implementation. And then we go on to evaluating implementation. And there are various frameworks and theories to support these approaches. So when we're thinking about describing what that process is, we can lean into methods around process mapping and use frameworks such as the knowledge to action cycle. When we're wanting to understand what influences implementation outcomes, we might look at determinants frameworks to get that understanding of barriers and enablers, and also lean into those classic theories and implementation theories that help us understand behaviour. We have evaluation frameworks. And I also have here equity frameworks, because more and more we're thinking about how we take on that equity lens to consider how our implementation might improve access to priority populations or limit access. So now these frameworks can be considered across various stages. So we can look at using them in pre-implementation and early implementation, once something's been implemented, and also during the scaling up of an intervention. And that can be in the form of these early feasibility pilot studies, or more and more we're seeing hybrid trials where implementation data is collected at the same time as we're establishing efficacy of an intervention. Right through to, when we're looking at full implementation trials where we're considering are our implementation strategies effective, to also then scaling these up. But when is the right time? When do we need to be considering implementation research? And this is usually when we have slow or low uptake of an intervention, or when there's unwarranted variation. We also might consider implementation research when there's low value care, so when we might be looking at de-implementing something. And also more and more we're thinking about incorporating implementation research when we're looking at developing interventions. And this process really enables us to think about optimising how we're going to go about doing this, and trying to address some barriers up front and consider if what we're doing is acceptable and feasible in practice. So I'd like to talk through, I guess, and present a bit of a four-step approach. So this is Simon French's well-cited paper that proposes that there's 4 steps to developing a theory-informed intervention. So the first is really around identifying who needs to be doing what differently, using the literature and your expert team to find what theoretical framework is going to work best for that project, and use that framework to identify and understand what the barriers and enablers are. And then, informed by that step, go on to then determine intervention components that can actually target your barriers, and then look at evaluating it. So if we take a little bit more of a deep dive into this first step, so it's really about understanding and identifying who needs to be doing what differently. And this step is really key, because in order to influence and change behaviour, we need to really be clear on what it is that we're wanting to do. So if we look at implementation science frameworks, the ACT framework developed by Presa is a really nice framework to help us do this, because it provides a systematic and structured approach for us to consistently specify what a behaviour is. And what we know from the evidence is that specifying behaviour makes it more actionable. So if we can be really clear on who needs to do what, when and where, we can improve our chances of uptake. And so now what we've done across various projects now is to look at how we apply this framework to the method of process mapping, to one, understand what the problem is, but also in those studies where we might be looking at informing how we go about implementing a new model. So an example of where the ACT framework was used to describe a problem was in the project on advanced care planning. So advanced care planning is a process of defining, discussing and documenting our preferences for future medical treatment and care. And it's significantly underused in cancer settings. And in fact, within Victoria, the Department of Health has a target for anyone over 75 years of age who is an inpatient. There should be 50% of those cases with documented ACPs. But the rates that we see in practice are as low as 9%. I think when we started this work at Peter Mac, it was 9%, 14% at Royal Melbourne, and the more hospitals that I speak to across Australia-wide, they all have these low documentation rates. So we really wanted to start to understand, well, what is currently being done and why is this different to guideline recommendations? And so we went about this by conducting a series of focus groups where we used process mapping and the ACT framework to kind of inform our approach. And what we tried to do was, in the first step, identify all the actions. So if we think about a health intervention, in order for us to kind of look at where the problems are, we need to be clear on what are all those steps. So we went through this process of mapping out what are all those little steps that need to be done to make up what advanced care planning is. And we did that from the perspective of health professionals, so across all different roles, and for consumers. And then we applied all the other ACT domains and said, okay, well, at each of these steps, what are the preferences around who should be doing this, when it should happen, where, and try to explore what the preferences were and if there were any differences. And we definitely found differences, which were quite interesting. But from a methods point of view, in taking this approach, we could find touch points across that pathway that were not working. So for example, when we're talking about actions that happen all the time or don't necessarily happen consistently, one of those points was around having that conversation around goals of care. And so this was something that health professionals were like, happens sometimes, patients were a bit the same. And when we looked at the preferences at this action point, it became quite clear that maybe things were not happening in a way that aligned. And so, you know, if we think about who is the most appropriate to have person to initiate the conversation, health professionals were saying, oh, doctors, and you talk to patients, they said, we don't want to have this conversation with doctors. And when we talk about the time, anytime there's a change in health status was a really strong, everyone agreed on that, but consumers were, we can have this conversation anytime, but when there's a change in health status. So using this method to kind of really hone in on where are our hotspots enables us to then focus on, okay, well, what are the barriers and enablers at this specific point? And not necessarily look at all the things that are working well. And if I talk you through another project, so this is a project led by my Kristen and looking at exploring how we digitally enable access to specialist nurse-led care for pancreatic patients living in regional and rural areas. So we know that specialist pancreatic nurses are a very scarce resource. We know that there's clear benefits in having that nurse-led care and involvement in your care when you have pancreatic cancer. So this project in the first phase was really to understand, well, how could we get this model of care into practice? So again, the ACT framework was really useful because we could look at, well, what are all the key actions from a consumer perspective as to what they would want in the model, and then, you know, explore all the preferences around it in terms of when it should occur, with whom, in what context, and then do the same thing with health professionals and identifying where there were different actions, where there were different preferences, and again, trying to address those potential barriers up front and how we can then inform the design of a model that aligns all the stakeholders' preferences to improve that chance of it being taken up in practice. Again, another new model of care was the Living Better with Myeloma project. So this was about embedding a survivorship model within a clinic that sees patients with multiple myeloma. And so, you know, over the past 30 years, there's been huge developments in treatment for this patient population, which means they're living longer, but there's no systematic approach to looking at those survivorship issues for these patients. So the two PIs, Amit Knott and Trish Joyce, who were leading this work, were really keen on embedding a survivorship clinic within their clinic that maintained these patients who were very stable and in ongoing maintenance therapy. So again, we, you know, applied the ACT to unpack, well, what are all the actions that we need to do to implement, and then explore the preferences. And this was a really good example of the difference between it seemed like a good idea at the time and using a systematic and theoretically informed approach. Because when this project started, they were really keen to have this clinic substitute one of the routine review appointments. But having all those people in the room, it became very clear very quickly that none of the doctors were going to be on board with this. And if we look at who we need to refer patients to the clinic, it was the doctors. So we needed to get them on board and then rethink about, okay, well, how do we implement this in a way that aligns preferences with all the people involved? And so once we can go through the process of specifying what are all those actions and identifying those hotspots that we need to target, we need to really think about barriers and enablers. And this is really crucial for successful implementation. And we know this because when it doesn't happen, we don't see change. And again, a classic example of this was in the context of advanced care planning. So when we looked at this initial work, we were really keen to go back to the literature and see, well, why is it underused in cancer settings? And so we did an overview of reviews and we used the theoretical domains framework, which is all about understanding barriers, to map all this out in the literature so that we can see what are the barriers that are in the literature and what are the interventions? But importantly, what barriers are the interventions targeting? And this was really interesting, and this table is presenting this part of the results. But what we found is that in the literature, all the barriers for advanced care planning, or the majority of barriers for advanced care planning, were for healthcare professionals. And then we had barriers for patients and at a health services level. When we looked at the interventions and the barriers they were addressing, well, they were targeting mostly patients and hit miss on whether they were targeting actual domains that were prevalent and important. Then there were a few interventions targeting healthcare professionals, but most of them weren't even hitting the mark on the main barriers that were being reported as to why advanced care planning wasn't happening. And in fact, none of these interventions were effective in improving any uptake, except for ones targeting healthcare services, which were the ones that were aligning to actual barriers. Surprise, surprise. So what do we do with this? We want to see, if we want to see positive change, we need to be firstly really clear on what it is that we're wanting to change. So understanding exactly what that process is, and then using a theoretically informed approach to identify our barriers and enablers so that we can inform this to develop and design interventions that will target actual barriers, but also using those active ingredients, if you like, or those right mix of methods in order to influence change. Now, we're really lucky in this space because if we use those frameworks to identify what our barriers are, a lot of them have published mapping tools that we can then cross over and map out what our active ingredients need to be. An example of this is if we use the theoretical domains framework, there's the behaviour change wheel, which is what I've got up here, which can map out to the domains that we find as the most frequently or most important barriers to a health intervention. And this is also the case for another framework, the CIFA, which I'm sure some of you have heard of. But again, we can use those published mapping tools to identify, well, what are the right behaviour change techniques that we need to include in our interventions to target what the barriers are. The final step is evaluating the implementation of an intervention and understanding how behaviour change can be measured. And at this point, it's really important to understand that we want to know, is there a failure of the intervention itself, or is there a failure in how we've implemented it? And this is, some of these frameworks can be really key in helping support unpacking that. And this figure here, taken from Proctor's paper, starts to delineate the implementation outcomes versus other outcomes such as service outcomes or client or consumer outcomes. So to evaluate implementation, we may choose one or two or various of these implementation outcomes. We might be interested to know, what's the acceptability? Is it feasible to implement? What was the adoption? But also we can use frameworks that can inform which outcomes we might want to consider. And one of these frameworks is the framework of implementability. So this framework proposes that we should evaluate 3 implementation outcomes, so looking at acceptability, fidelity, and feasibility. And that it also proposes that these outcomes are related and also provides a guide on when we should look at it. So anytime we're taking an intervention or designing a new intervention, we need to look at things like acceptability, can it be delivered as intended, fidelity, and is it feasible to implement? And then anytime we take that intervention to another context, we need to revisit and assess that because there'll be different resources, different attitudes, different cultures, and all those same barriers that can come into play at the previous setting. So another well-known evaluation framework is RE-AIM. Now, this framework explores those implementation outcomes around reach, effectiveness, adoption, implementation, and maintenance. So that's sustainability. And I thought this was another good one to put up because it's recently been updated to really focus on the equity impact and looking at sustainability and exploring how equity and contextual factors vary across those implementation stages. Conclusion, I feel like I have sped through this. Conclusion and takeaways. Well, implementation science is an evidence-based, theoretically informed approach to bridging the gap. It does that by tailoring interventions to specific contexts, making them more effective and more scalable. It improves efficiency by focusing efforts on strategies that are likely to succeed in those real-world contexts, and evaluates not just whether an intervention works, but how it can be maintained over time and adapted. So when we're thinking of scaling and how we can go about doing that. By incorporating implementation science, health research moves beyond that discovery phase to ensure that interventions have a meaningful and sustainable impact on patient care and public health. And I really hope I have inspired all of you to take these theories into the workshop that is happening after lunch and see how you can apply some of these thoughts in practice. So thank you everyone for your time.
Thanks, Lisa. We do have time for questions. If anyone has a question, please raise your hands and I'll walk over to you with the mic.
Yell out if you want. Thanks, Lisa. Great talk. Jason Tribbiano.
Thank you.
The confusion from a clinician lens is that the implementation frameworks are numerous, overlapping, and sometimes they sound all the same to me.
Yep.
Do you have some hot tips or favourites that you think resonate with AMS implementation programs, mainly from an evaluation lens? I think that's where I often get confused.
Yeah, there are a lot, and I think there are definitely favourites, and I think it really comes back to drawing back exactly. I like to go back to, well, what is it that you're trying to answer? What does success look like? And thinking about, I guess, what are those barriers and enablers, and how we go about addressing them, and then what's the impact we want to achieve. So I love the CLAIC implementability framework. I think it provides that it's just clear to understand when we're thinking about what are those three main things that we want to know work, so that we can say that something is working in practice. And we want to know that there aren't too many barriers to implementing something. So thinking about that feasibility, can we actually do it? We want to know that it can be delivered with fidelity. So when we're taking something and we know that it works well, can it be applied as intended in another setting? And acceptability, and I've heard appropriateness being talked about a lot, but for us, I guess acceptability and appropriateness is the same thing. It's quite similar. So that to me is quite key in evaluating any intervention. So you want to know that the people using it believe in it, and that it's not really burdensome, and they're happy to adopt it. Because if you've got people who think something is acceptable and it's easy to do, they're more likely to do it. So that's, yeah, thanks.
Any other questions?
How do you approach hybrid studies? Because I have seen, Lisa, quite often people tacking the implementation on to almost tick a box, and it's really driven by the effectiveness trial. How do you go about that?
Yeah, and again, it depends on the study and which hybrid trial. If we're looking at hybrid trial, type 1, where we're establishing efficacy of an intervention, it's really about getting that information that we're going to need to take it to the next step. So really focusing on those things that, that's going to be important for us to consider, well, how is this going to work in another context? So, I guess, focusing on those kind of, it's a hard question to answer because it depends on the study, right? So we want to know exactly what that study is and then look for where it sits in that timeline and what are going to be the most important implementation outcomes to look at for that study.
Probably got time for 1 or 2 more questions. Okay, I might wrap up this session.
For our next presentation, we actually have 2 presenters. First up is Dr. Kristen Bailey, who is a vet and senior postdoc research fellow with NCAS and the Melbourne Vet School. She's got expertise in microbiology, infectious diseases, biosecurity, and antimicrobial resistance and AMS in the animal population. Thank you, Kristen.
Okay, so the topic for my talk that I was given was practice-changing research in veterinary antimicrobial stewardship. I have a disclaimer to make. I think my talk is mainly about research to generate sufficient evidence for us to be able to implement some practice-changing research. But hopefully you'll still find it interesting. So I'm going to talk about 3 antimicrobial stewardship initiatives today that are contributing to the evidence base for changing behaviour in veterinary antimicrobial stewardship. So the first one is this group called the European Network for Optimisation of Veterinary Antimicrobial Treatment, or ENAVAT. And so this was a cost action funded by the European Union that ran for 5 years and finished up in May this year. And it brought together over 200 members, including researchers, veterinary clinicians, microbiologists, pharmacologists, epidemiologists, infectious disease, behavioural scientists, and public health experts across Europe. And they had 5 working groups. I'm going to touch lightly on some of the key things that they have achieved with this. So the first working group was to map microbiological diagnostics and treatment guidelines. So looking at the diagnostics, they wanted to describe, compare, review diagnostic laboratory methodologies and interpretive criteria across Europe for ID and AST of veterinary pathogens. And just a heads up, so in veterinary science, we still don't have clinical breakpoints for many animal pathogens. And the default is that we use the human breakpoint, which really doesn't mean a lot in whether a treatment is going to be effective in a dog or a horse or a snake. And so this initiative was trying to address some of those gaps, which was fantastic. The other thing is, so I had a PhD student that was looking at AMR in snakes, and trying to identify the bacteria was a real problem because the database doesn't have a lot of reptile organisms in it. So part of this ENAVAT group was to develop, to see what criteria people were using. They created a position paper highlighting the need for harmonisation. And then they surveyed 290 labs in 34 countries. And they identified that routine screening for methicillin resistance was only occurring in 48% of isolates and ESBLs in 46% of isolates. So I thought that was not surprising to me at all, but something that needs to be addressed. And then the second part of this working group was to look at what guidelines are available, what's the structure and the evidence base of them. And they just looked in Europe. And so they produced a paper that was an overview and an evaluation of available guidelines. They found 15 resources from 11 countries, and they used the agree-to analysis tool to look at how the guidelines performed. And one of their key findings was that the methodology was poorly reported for how the evidence was evaluated and how recommendations were formulated. They then surveyed veterinarians across Europe to find out about their awareness of guidelines and their engagement. They had over 2,000 vets respond from 46 countries, and they found that there was a correlation between awareness of guidelines, and they had some proxy measures of appropriate AMU where they had a series of questions about when it was appropriate not to use antibiotics. And in this chart, our blue bubbles represent countries that had their own guidelines, and the pinky coloured ones are countries that don't have guidelines. And you can see that countries with their own guidelines tend to rate higher with awareness of appropriate use. And so one of their recommendations was to try and get more national guidelines out, although I imagine it's really just taking the same guidelines, because the drugs didn't change that radically, and putting a name on it that they're national. But anyway. Of guidelines that are available, the participants' greatest familiarity was with these two resources. One is Ficava from the Federation of something Veterinaries in Europe, which is a poster, and the other was this SIVA Graham book. They surveyed veterinarians on what the priorities were for the content of guidelines. Not surprisingly, choice of antibiotic rated the highest, followed by duration of antibiotic course. And I have to say, this is a well-known knowledge gap for us in veterinary medicine. We don't have much data. I guess with large animals, often there was a bottle that was 100 mils, and 20 mils fit in a syringe quite well and was okay to inject into a cow. And so you could get this many doses out of a 100 ml bottle, and that's sort of how it worked. We are learning from our human health colleagues to try and shorten our duration, but we really don't have good, large randomized clinical trials to back these decisions. Although one of the authors and members from NCAS is conducting a prospective trial. So the second working group was looking at creating a European strain database. And so they surveyed the different laboratories, trying to figure out what their priority list of pathogens was that they wanted to get a strain library of. And they got 26,000 isolates from 24 countries. And then they're going to use these to refine the MALDI-TOF database so that they can recognize some more of the veterinary pathogens. Probably the reptiles aren't up there on their top list of priorities. And they're also going to determine some more ECOFs. And then once they've got the ECOFs, their working group 3 was developing clinical breakpoints. And this is so that we can have some susceptibility test results that we can actually use to inform our treatment decisions. And one of the side benefits of this was that because it was such an interdisciplinary team, and they had pharmacologists and a whole bunch of people working together, as they requested data from the pharmaceutical companies, because there's not a lot of publications on what is effective doses for us, and they were able to remodel some of that. And so when they created their clinical breakpoints, they also produced 3 papers highlighting some appropriateness of dosing, which is really useful when you then come along to try and develop guidelines. So that was working group 4's task, was to develop evidence-based treatment guidelines. And they started off by creating a standard for how evidence-based guidelines should be created. And they involved some human medicine methodologists. And then their plan is to write guidelines for 6 diseases in a number of different species. And so they started off with systematic and scoping reviews, and they've published those on surgical prophylaxis, acute diarrhea, colibacillosis in poultry, and mastitis in cows. And then they're going to go on and develop guidelines, and then they want to promote transformation of those NCAS guidelines into national or regional guidelines. And so one of the achievements is this, that they're building veterinary capacity for guideline methodology. So they've brought in methodologists from human medicine, and they've also had training from ESCMID and GRADE experts. And they have published the guidelines for acute diarrhea. I did review, they have a paper that's an overview of all their work, and they claim that these are the first evidence-based antimicrobial use guidelines developed for the international veterinary community, which I did query, but they're saying that theirs is the most rigorous methodology, and that the ISCAD, which is the International Society for Companion Animal Infectious Disease guidelines, were more consensus-based, but in the future, they'll be more like theirs. So the surgical prophylaxis guidelines should be coming out soon. So you can see that this group has achieved quite a lot in 5 years. This is their diagram of an overview of what they've done, and if anyone wants to look into it further, it's in that publication. So the next thing I'm going to talk about is a project in Wales where they were creating a network of national veterinary prescribing champions, and these were all farm animal vets in Wales. And so they managed to recruit 41 out of 50 farm practices in Wales, which was about 80%, which I think is amazing. And the goal of the project was to improve those champions' knowledge of AMS, the evidence base for prescribing decisions, the legal and regulatory framework, and human behaviour change. And then in creating a network, rather than just lots of champions, they wanted them to be a network and to foster a sense of community and identity. And then encourage the dissemination of the AMS messages within the network, but also within the practice. So they had 2 phases for this program. The first was the development phase, where they had their expert panel of researchers from Bristol University. They had stakeholders such as farm industry bodies, veterinary associations, government policy departments, human public health. They did an informal survey of the veterinarians to just try and identify any key issues that should be included in the program. And they did a literature review. And then they used the self-determination theory for behaviour change to design their program. So once they designed their program, they recruited their veterinarians and their network, and then they had a series of training activities with the goal of creating a champion mindset in these champions. And at the end, they wanted each champion to implement one bespoke antimicrobial stewardship intervention in their practice. This is just some of the inputs and outputs of the training program. So after recruitment, they were given some resources. They had some introductory webinars followed by a discussion group. They tried to have the discussion groups every 3 weeks, and they would discuss stuff that was covered in the webinars, as well as additional things. After 6 webinars and 3 discussion groups, they had a workshop where they workshopped for 3 hours the interventions that each stewardship champion was going to do, and they had to say what they were going to do, when and how, etc. And then they had another workshop where they sought feedback from the participants on what recommendations they had for policy. Some examples of what types of interventions they were thinking about was reorganising the dispensary to make it harder to find 2nd or 3rd tier antimicrobials. A common one that came up was scheduling training to improve communication with the veterinary reception and dispensing staff to make sure that there was a unified message coming out from the practice. They began to benchmark antimicrobial use among practice farms and include discussion of antimicrobial use at annual herd or flock health planning visits. And they also thought about introducing on-farm medicine covered health checks into the herd, flock or health planning. So in farm practice, you quite often dispense a bottle of antibiotics that, particularly on a sheep farm, the sheep dose might be only 8 mils, so a 100 ml bottle might last quite a while. And there's a tendency to stash that away and keep it for 10 years and it's sitting there out of date. So having this farm cabinet review each year provides an opportunity to have a discussion about getting rid of some of those medications and so forth. And then they said that the interventions would, when they were being implemented, that the champions were to provide monthly reports on the feeding back on the ease of implementation, the relevant actors, the scope of changes, the outcomes observed, and any barriers encountered, and that there'd be a longitudinal prescribing audit to evaluate the prescribing behaviour. Unfortunately, that implementation was supposed to start in January 2021. There's no publication yet. I'm really hoping that they do publish how it all went. But in the meantime, the network of champions have gone on to develop a code of conduct. So there was concern that one of the common concerns in veterinary practice is that if the vet doesn't give the farmer what they want, that they will go to the vet down the road. And so that was raised at one of those early discussion groups and in the survey. And so that was built into the design of the project. And that's partly why they wanted to foster this community between the champions. And they've developed a code of conduct for what a proper relationship should be for prescribing. So you needed to be a core, sorry, let me just. They had some definitions around being a core providing practice to be able, so they had to meet certain criteria to be able to dispense medications such as antibiotics. And so they're hoping that that will foster a better community response and help change the way that farmers request and shop around for antibiotics. And they've also created guidelines for 6 diseases in sheep and cattle. And then the last thing I was going to talk about, this hasn't been published, but I thought it was a nice One Health activity where this is the 3rd year that they've had an antibiotic amnesty in the UK, and it's sponsored by Zoetius this year. And so the idea is that the practice has a container in a safe but accessible area, which has a label on it for disposing of containers, and they encourage their clients to bring any unused antibiotics back into the practice to be safely disposed of. And so they want the practice to have a talk internally with their team. They want conversations with clients every time they come in for a consult, encouraging them to return any unused antibiotics. And they provide a whole heap of campaign resources on a website. And some of the ideas for supporting conversations, they give you a template for some stickers so that every time a medication is prescribed, the sticker can be put on there to say, bring back unused drugs. They encourage people to add it to the practice newsletter. You could put a sticker on the vaccination reminder or add some text in there. And also they suggested calling owners that had had a recent prescription to see if they had anything left over and wanted to bring it in, which I think one of the things is, they're just doing this for 1 month of the year, potentially works better than if you've just had an infection. I imagine people are a bit like, oh, it might come back, I want to hold on to it. Whereas if it's a more distant time period, they might be a bit more like, oh yeah, I'll get rid of that now. And yeah, they have a hashtag for and resources for social channels. And then after the antibiotic amnesty, they're supposed to have kept a record of the number of conversations they've had with clients, but also they count up what antibiotics have been returned and report that back to the organisers. So they haven't published it, but there is a report from 2023's amnesty. They had about 300 practices sign up, but 111 actively participated. They have a campaign website page that had nearly 2,000 individual users. They had 2,500 tablets returned, 119 packets of topicals, 160 bottles of oral suspension. So some quite good returns. And just for comparison, in 2022, they had they only had 66 actively engaged, and they had about a third of the number of tablets, half the number of topicals, but they had more injections. The majority of antimicrobials returned were originally intended for use in dogs and cats, with a smattering of rabbits and reptiles and other animals. And just looking at what types of antibiotics were returned. So we've got fluoroquinolones in green, and we've got 2022 on the left and 2023 on the right. And the pattern's fairly similar between years, of amoxiclav being the most common one returned. And this was a One Health approach because there were also the Royal Pharmaceutical Society had links on their page to the veterinary resources as well as their own pharmacy campaign. And in the report for the veterinary amnesty, they also had a few results from the Midlands NHS campaign. So in summary, I've covered 3 different AMS initiatives, the European group with the development of how to create guidelines and providing some guidelines, developing ECOFs and clinical breakpoints, providing some evidence for us to then use when we're trying to change behaviour. I talked about the Veterinary Prescribing Champions Network, which has built a community in collaboration between farm veterinary practices, and hopefully we get to see some more publications about what impact that's had. And then the antibiotic amnesty as a One Health approach to the safe disposal of unused antibiotics and hopefully reducing treatment that's not guided by a prescriber. Thank you.
Thank you so much for that, Kristen. So our next presenter is Dr. Satwik Motaganahalli. So Satwik is an ID and AMS physician at Austin Health with a particular research interest in diabetic foot infections and bone and joint infections. And he's also currently completing his PhD through the Department of ID at the University of Melbourne. Thank you.
Hi, everyone. Thanks for inviting me to speak. So I was also given the topic of practice-changing research, but in human health. And when I sort of thought about the papers that I'd read over the last 12 months and did a bit of a literature search, it was actually hard to find much that truly changes practice over a short period of time. So I thought I'd also talk about papers that I just found interesting that probably, in my mind, posed some, or gave me some ideas for potential future research or how to implement what other researchers have done in research that we do. So I guess I'll probably begin with the biggest papers that were published in AMS over the last 12 months, which were the INSPIRE RCTs that were published in JAMA. There are a pair of cluster randomized clinical trials aiming to compare the effect of routine antimicrobial stewardship versus a computerized provider order entry bundle on how clinicians selected empiric antibiotics. And this was an electronic bundle that was activated anytime a patient was prescribed an extended spectrum antibiotic within the first 72 hours of their admission. And that created an algorithm that was sort of individualized to each hospital that went through a bunch of prompts, a series of prompts for the clinicians to fill in to assess the risk of patients having multi-drug resistant organisms. And if the risk was less than 10%, it triggered a prompt that recommended a standard spectrum antibiotic. And this was tailored to the specific antibiotic ordered. So if they were ordering vancomycin, they'd go through prompts for MRSA. If they're ordering, something that covered multi-resistant gram-negatives, they'd go through prompts for that. And then they were also altered for the specific hospital based on their local microbiology. And so they did 2 trials, one on pneumonia and one on UTI. And then both groups that were participating in this trial were also educated on the national standards for empiric treatment for these conditions. And then those that were allocated to this computerized bundle, they were also received education on how they did the MDRO risk calculations, what the local frequency of MDROs were for these indications in their studies, in their sites. So for pneumonia, they recruited 59 hospitals, a large number of patients, so nearly 50,000 women and 46,000 men, and about 30 hospitals each to getting the bundle versus standard antimicrobial stewardship program. And the primary outcome they were looking at was days of therapy of extended spectrum antibiotics. And they found quite a significant difference. So in the computerized order bundle, there was 0.68 rate ratio of extended spectrum antibiotic therapy compared to 0.94. So that was a 28.4% reduction in empiric extended spectrum days of therapy in pneumonia. And similarly in UTI, they did the same thing, had a larger number of patients, again, 59 hospitals in the US, and they found a 17.4% reduction in empiric extended spectrum days of therapy. I think these were probably the 2 biggest trials and very well-designed trials that were done in the AMS space over the last 12 months. They also looked at secondary safety outcomes, days to antibiotic escalation, days to ICU transfer, hospital length of stay, and they were all similar in both groups. So I think the significance of these trials is that these computerized prompts can be useful to reduce unnecessary extended spectrum antibiotics, and they're probably quite similar to some of the pre-prescription approvals processes we use through systems like guidance. But what I quite liked about this is that this process of going through how to calculate your risk of MDRO, I think probably gets the clinician thinking a lot more about why they're choosing certain antibiotics. You know, if in a lot of our systems, if you're ordering an antibiotic for pneumonia, you might go through a score looking at grading severity and then helping you choose the antibiotic. But having clinicians think through why they would choose a certain antibiotic, you know, assessing the risk of MDROs early in admission, I think engages the clinicians a little bit more in understanding their, you know, helping frame their thinking for choices of antibiotics. And this sort of algorithmic approach early in the admission could also reduce the need to wait for cultures prior to de-escalation. And I think this is something that with a lot of electronic health systems could be implemented. So I think it's quite, they're quite important RCTs and something that we can also use in Australia. The next paper I wanted to talk about was this one. It was published in Clinical Infectious Diseases, and it was called Preventing New Gram-Negative Resistance Through Beta-lactam De-Escalation in Hospitalized Patients with Sepsis. And it's a retrospective cohort study. So, I mean, it's not necessarily a practice-changing study, but I think some of the methodology that they used is interesting and potentially useful for research that we might be doing. So this is a retrospective cohort study in St. Louis, where they looked at adult patients who were coded for sepsis and received more than 3 days of beta-lactam with an antimicrobial spectrum score of more than 7. I'll talk a little bit more about what the spectrum score is. So the interventions they were looking at was, what they were looking for was de-escalation of beta-lactam spectrum, so a reduction in the beta-lactam spectrum score or an increase in the beta-lactam spectrum score, which they sort of thought of as de-escalation or escalation of antibiotics, and comparing that to no change in the beta-lactam spectrum score. And the outcome they looked at was, I think, quite an interesting and useful outcome, which was isolation of a new drug-resistant gram-negative isolate from a clinical culture within 60 days. Now, there's a retrospective study, so these are clinical cultures. They're not doing routine screening for resistance, so they probably missed a lot of resistance. But I think it's always useful to think about resistance, which I think we don't often do. So they looked at over a 7-year period, and this was the beta-lactam spectrum score they used. And I found this interesting because I've seen a few papers over the last couple of years looking at beta-lactam spectrum scores. I think there's about 3 or 4 different ones that have been published, and they're all created slightly differently. I mean, we use metrics like days of therapy, appropriateness, but this is another one that's sort of a little bit more in vogue nowadays, but I think it's still pretty new in its inception. So this is quite a simple score that they've used, where they give 1 point to sort of each type of organism an antibiotic covers. Some of them are weighted less at 0.5, and then they rank them in terms of how many different organisms or types of organisms they cover, from being narrow to broad spectrum. So they had a large number of patients, 7,700 patients, with about 4,800 that had no change, and then about 1,500 that were de-escalated and 1,300 that were escalated. They had similar baseline characteristics in all the groups, and they found that the incidence rate of developing new gram-negative resistance the total incidence rate was 1.85 per 1,000 patient days, but it was lower at 1.42 in the de-escalation group. So this was a statistically significant reduction in development of new gram-negative resistance with de-escalation compared to no change. So they stated this in their discussion, and I think it's true. I haven't come across other papers, but someone might correct me, that this was the first study that actually demonstrated that beta-lactam de-escalation actually reduced antibiotic resistance in gram-negatives. But what I found really interesting was the spectrum scores, and I think they may be a useful objective measure of de-escalation, but there are other factors that we probably need to consider in development of resistance, like how long patients are on treatment for, and it's still unclear which specific spectrum scores is significant, and whether spectrum alone is important. An antibiotic like Pip/Tas probably has a higher spectrum score than Augmentin, but in terms of development of resistance, is there a difference in terms of Clostridium difficile rates? Is there a significant difference? Probably less so. They did try to conduct a sub-analysis to account for days of therapy, but the results were non-significant. But I think what I found interesting about this study was the use of the spectrum score, and something that I'm interested in seeing more, and whether we can use this in other research that we do. The next study I want to talk about was this one. This one, in some ways, may be practice changing. So short post-operative IV versus oral antibiotic therapy in complicated acute appendicitis. So this was a pilot non-inferiority randomized trial published in the Annals of Surgery. So this was a single-centered non-inferiority open-label RCT where they took adult patients with acute appendicitis undergoing a lap appendicectomy, and they randomized them to either 24 hours of oral augmentin therapy or 24 hours of IV augmentin therapy. And then the treating physicians were allowed to extend these courses if they felt it was clinically necessary. And they looked at 30-day postoperative complications as their primary outcome. And they recruited over a 3-year period and recruited just over 100 patients with about 50, just over 50 in each group. And importantly, the majority of these patients had gangrenous appendicitis. So these were complicated appendicitis patients. And they found essentially very similar complication rates in the intervention groups versus the control group, similar length of stay. So, showing that early oral antibiotic therapy in these postoperative patients was similar. Now, this is a pilot RCT. They didn't do a sample size calculation. There actually aren't many studies, prior even observational studies, to do a good sample size calculation. So they were unable to confirm true non-inferiority. But I think a lot of us may already do this in clinical practice, where we try and get our surgeons to switch to oral therapy when they're when patients are able to have oral therapy. And so I think this study certainly supports early oral antibiotic therapy where it's tolerable, and it is our practice in a lot of settings. And if it's not for other people, it may change your practice. The next paper I want to talk about was this one in the BMJ, which was targeted towards primary care physicians. It was mailed feedback to primary care physicians on antibiotic prescribings for patients aged over 65, and this was a pragmatic factorial RCT. So this was done in Canada, where they looked at primary care physicians in Ontario who are prescribing antibiotics to patients over 65. And they had to pick patients over 65 because in Canada, if you're over 65, your prescriptions are publicly funded. So they had data on all these antibiotic prescriptions that primary care physicians were giving. And the intervention was a letter that was mailed to physicians with peer comparison antibiotic prescribing feedback. And they compared that to physicians not getting a letter. So they recruited 4-to-1, where for every 4 patients recruited to the intervention group, they recruited 1 to the control. And they did a further randomization in this factorial RCT, where of the 4, for every 4 physicians in the intervention group, they were given different letters. So one would get a letter that had the measures adjusted to similar physicians in their areas, based on their type of GP practice, what they were, the caseload, the area. And whether or not they got a part in the letter that talked about the harms of overprescription of antibiotics. One group got adjusted measures and harms, one group got adjusted measures, no harms, another group got unadjusted measures and harms, another group got unadjusted measures and no harms. And the primary outcome they were looking at was antibiotic prescribing rate per 1,000 patient visits for these patients. So they mailed this letter in January 2022, which I think is important because that was still COVID times. And they looked at prescribing rate for the 6 months post mailing of the letter. So they had quite a large number, over 5,000 physicians that were part of the study, with 1,000 in the control group, 4,000 in the intervention group, split in 4 ways into the 4 different letter types. And they looked at mean antibiotic prescribing rate. So it's not a huge difference, 56 patients per 1,000 patient visits were given antibiotics versus 59.4 in the control group. But it was a 5% reduction, and it was statistically significant. And when they looked at to 12 months, this was still sustained, where the intervention group still had lower antibiotic prescribing rate. So I think you have to think about the timing of this as well. I suspect a lot of consults were telehealth consults. And I think in that setting, it's a bit harder for physicians to confidently not prescribe antibiotics if you can't really clinically assess the patient. So perhaps that might have impacted these results. But certainly still there was a significant reduction, even if it's not a massive reduction in amount of antibiotics prescribed. And they also found lower rates of unnecessary prescriptions and lower antibiotic prescribing rate for what they termed long duration prescriptions or broad spectrum prescriptions. And then in the embedded factorial trial where they did the different types of letters, they really didn't find any difference with the different types of letters, whether the feedback was adjusted for that GP versus unadjusted, or if they had a spiel about the harms of antibiotic use. So I think it was more just the presence of the letter seemed to make a difference to get physicians to think about their antibiotic prescription. So the written feedback alone clearly reduced prescription rates. And it's quite a simple, nice, clean intervention they did using available data. And I think it's a good example showing that peer comparisons affect prescribing behavior. I know in the last interactive session we did, talked about peer-to-peer comparisons for surgeons. I think this is good data that shows that it does make a difference in how people prescribe antibiotics. The next study is far from practice changing, but I think I found it quite interesting. This is a retrospective cohort study looking at dosing and treatment duration of suppressive antimicrobial therapy in orthopedic implant infections. And I think this is something that a lot of us ID physicians do, but it's probably not something that AMS services look at because it's prescribed by ID physicians and we often don't audit ourselves. So this was a single center retrospective cohort study in the Netherlands, where they looked at all patients with prosthetic joint infections, fracture-related infections, and spinal implant infections that were on what was termed suppressive antimicrobial therapy. And they want to compare low dose versus standard dose suppressive antimicrobial therapy, and their primary outcomes was failure-free survival, and they had different things that constituted failure. And they looked at over an 11-year period, and this is what they termed low dose versus standard dose. I think looking at this in my own practice for the beta-lactams, I probably mostly would be using low dose, what they would term low dose for suppression, but I certainly wouldn't be using what they would term low dose for some of the other things like Bactrim or linezolid, rifampicin. I'm probably often using higher dose if I'm using suppression. So they didn't have a huge number, they had 108 patients, with the majority of them being on low dose suppressive antimicrobial therapy and a smaller number on standard dose. Majority had prosthetic joint infection. The majority were on beta-lactams, about 60 to 70% were on beta-lactams for suppression. And they found no statistically significant difference in failure-free survival, but I think you can see that those on low dose did have a lower number without treatment failure. And then the similar frequency of side effects in both groups. This is far from a practice-changing paper, but I think it's important because it's an area that we actually make up most of the time. These patients are on antibiotics often lifelong if the implant is left in place, and the evidence for the benefit of long-term suppression is pretty poor. We don't really have any good data on if these patients can ever stop. The patient population is very heterogeneous, and they're really hard to assess and research. And low dose would be great if it provides equivalent benefit, certainly in terms of patient adherence and costs, but we don't really have any meaningful data on how long-term suppression impacts resistance, antibiotic-associated adverse effects, what the patient experience is. I just put this really nice review paper that was done by local colleagues in clinical infectious diseases earlier this year. I think it's worth a read. It's a review paper of the evidence that's out there on long-term suppression. But the Australian Orthopaedic Association has a national joint registry that they collect data on everyone that gets a joint replacement and complication rates. But this is the kind of thing where if we had a long-term registry on patients on suppressive antibiotics, we could potentially find, how we best manage these patients or what factors might affect those that need to continue, those that fail, those that we can potentially stop. And we often forget about these. They're often managed in the outpatients or in a private setting. And I think this is an area where stewardship is also important. The next one I want to talk about was this one, focusing on the ED setting. This was a systematic review looking at rapid respiratory virus testing in EDs. So the question they wanted to answer was, does rapid respiratory virus testing in ED reduce antibiotic use? And this has become very common in a lot of Melbourne centres since COVID, certainly, but they were there for flu, influenza prior as well. And they looked at RCTs that had patients presenting with acute respiratory illness that were evaluating the clinical effect of routine use of ED, rapid respiratory viral testing, on physician decision-making. They had found 12 RCTs, and this was pre-COVID. So they had a few that tested for influenza only and a few that tested for multiple viruses. Importantly, the majority of the patients that were included in these trials were children, but there were still 16% adults. And essentially what they found was it really made no difference in overall antibiotic use, whether or not these EDs had rapid respiratory virus testing. We'd all like to do stewardship in ED, but it's quite difficult. One of the ways we'd like to improve it is probably by having rapid diagnostics. But what they found was when there was a positive respiratory virus on one of these tests, there were fewer patients getting antibiotics, but when they were negative, more were being prescribed antibiotics. Now, they may all be appropriately prescribed, but I guess what it sort of says to me is that they may be useful, these tests may be useful to rule in respiratory virus. They may assist in appropriate antiviral use. For example, if you've got influenza, and positive results may reduce antibiotic use, but negative results might increase the rate of antibiotic prescriptions. And I think it probably goes to show that not every test can give us a positive answer. A lot of these are undifferentiated illnesses, and it probably still, unfortunately for emergency department, antibiotic stewardship is still very reliant on education of clinicians to improve their prescribing. It is unclear how COVID's changed this finding. Certainly anecdotally, I think during the height of COVID, when we were infectious disease and antibiotic stewardship teams were really involved with COVID, was probably pretty good, where we were really looking and trying to assess whether these patients needed antibiotics. But since we've pulled back and it's sort of becoming more ED and Gen Med managing these patients, anecdotally, I certainly feel that a lot of these patients are getting antibiotics far more frequently than they should. So I think it's another area that we should probably think about. And then I had to include some shorter is better studies. There are quite a few observational studies that sort of confirmed shorter is better for, especially in sort of the hem-onc setting. But I've only put a couple of the trials that I found in here. So firstly, this was the top one is called the REGARD VAP trial, which is a ventilator-associated pneumonia trial, an open-label non-inferiority RCT of ICU patients from Nepal, Singapore, and Thailand who met the CDC diagnostic criteria for VAP. And they were randomized to short course, which was less than 7 days, less or equal to 7 days, or what was standard care in those sites, which was more than 8 or more days. So the way this trial worked was that they would assess patients after 3 days to see if they met a predetermined criteria for stopping antibiotics, which was sort of based on clinical improvement. Then they'd do the randomization, and if they were randomized to the short duration, they'd contact the clinician and say, hey, you can stop, which is probably what we may do in an AMS service. And then the other comparator arm just got standard care, which was greater than or equal to 8 days, and the clinicians decided how long the patients need to be on antibiotics for. And they essentially found mortality was 81% in the intervention group, 88% in the comparator group, but statistically non-significant difference. And the recurrence of pneumonia was quite similar. So I think, probably what we often do in an AMS service is go in and see, is this patient ready to stop? And this is sort of a data that helps us convince ICU clinicians to stop if they're meeting certain clinical endpoints. The next one is this one from the American Journal of Gastroenterology, published at the end of 2023, looking at patients with who are adults with moderate to severe cholangitis undergoing successful biliary drainage. So this was a single center open label non-inferiority RCT. I didn't put this in the slide, sorry, but there were 60 patients in each group, and they were randomized to short duration, which was 4 days of IV antibiotics, to conventional duration, which was 8 days. And they also found essentially very similar rates of clinical cure. So our local guidelines, I believe, in therapeutic guidelines are for 5 days after successful biliary drainage, but we probably would go to orals earlier as well if patients are tolerating. So this doesn't necessarily change practice significantly, but I think adds to us convincing surgeons to stop antibiotics post biliary drainage in these patients if it's been successful. Lastly, I also want to mention this, and Narelle mentioned this paper earlier this morning, done by the MDU group and Austin group about rifaximin prophylaxis causing resistance to daptomycin. So for those who missed it, there's a retrospective observational study. They used whole genome sequencing, and they demonstrated that rifamycin exposure, including the prophylactic use of rifaximin, was linked to development of daptomycin resistance. So I think this was really important because a lot of these antibiotics are prescribed by non-ID people and outside our domain. So gastroenterologists and hepatologists often prescribe this. And there are other indications for which they do similar. One of the things that always annoys me is the fistulizing Crohn's disease patient on months of ciprofloxacin, or pouchitis getting ciprofloxacin. And they're sort of, we don't follow these patients up because they're often in the outpatient setting. They're missed by AMS services. And I think the evidence is sort of not amazing. And no one really studies how this affects antimicrobial resistance. So this was an example of what a lot of people would consider a low-risk antibiotic regimen in long-term rifaximin prophylaxis, demonstrating a clinically significant development of resistance that I think is quite important. AMS research obviously can take many forms. We've had a lot of talk about implementation and qualitative, and I simply didn't include those papers because I'm not very good at understanding them. I'm still trying to learn how to read and understand implementation science papers and qualitative research, hopefully I'll be better at it in the future, but I think that they're equally as important in AMS research. But what I've sort of taken out of it was that we probably should also consider outcome measures beyond days of therapy. So I think spectrum scores are interesting. I'm not saying that we necessarily need to start using them, but I think we should keep an eye on them as potential way to measure the success of AMS interventions. And I think it's always important to think about development of resistance. I think in trials that I'm, a trial that I'm doing now, I'm sort of wanting to do another study looking at how changes in antibiotic prescribing affects resistance in the future. Any clinical trial that we do in ID where we're prescribing different durations of antibiotics, I think it's a nice sub-study for us to think about how does it impact resistance rates of colonizing organisms or development of resistance. And always we obviously want to look at clinical outcomes in AMS studies. And then the final thing is that all antibiotics are important for AMS and AMR. So I think we should think about prophylactic antibiotics, long-term suppressive antibiotics, and what we might consider traditionally low-risk antibiotics for research in AMS and AMR. Thank you. That's the end.
Thank you to Satwik and to Kristen for those two excellent presentations. And then finally, to finish off the day, I'll hand back to Kaz.
Thank you, Satwik and Kirsten. One topic we didn't really cover today, and that is if we are going to do clinical trials in the treatment of infections or in antimicrobial stewardship, how can we better design them to capture the implementation challenges? They are called hybrid trials. We will try and cover that with our new CRE. We're going to be having a lot of methodological sessions, and if you are interested, we can certainly invite you along when we start to talk about the methodologies of how to design a trial where you've got implementation science built into the clinical trial design. So not only do you get your cost, your effectiveness, but you can also understand whether that's feasible. So that JAMA CPOE, I was invited right here with Preeti Milani, the JAMA editor, and Stephen Tong to discuss those papers. And they were classic examples of whiz-bang US studies with zero information about the implementation, usability, feasibility, sustainability, and what happened. And they're actually performed in communities where there's very low rates of resistance. So, you need to dig deep you see these big headlines in a big journal, but you need to dig deep to understand what they actually mean. And when you start to do research, as I often say to my PhDs, it's not the discussion and the conclusion. When you start to design your research, you need to go into the methodologies of those papers and really deeply understand what the data means. What are the data models? What are the analysis? What are they actually trying to do? Because that's where you will find opportunities to continually improve what's happening. So that was a great session. So in wrapping up today, I'd like my RMH guidance team to come down, please, up to the front. Where are you? Rachel, come down here. She's hiding. Come on. just a, Josie, yep. So this is the team that put this day together. As you can see, I'm incredibly fortunate to have the group of people in my department that makes me smile every time I come in. They're so enthusiastic, so intelligent, just so forward-thinking and innovative. So you may or may not have met all of them, but Nanha is a senior AMS pharmacist at implementation lead for guidance. Rachel is an office manager and works with our quality management system. Jenna Malecki is a long-standing AMS pharmacist at Royal Melbourne Hospital, has been integral working with the guidance team, a lot of work on the decision support. Zohar Rashidzada came to us, coached her from the Alfred, an amazing, again, senior AMS pharmacist is working with the guidance team. Josephine Wen is leading our NAPS program management, and Kaz Chen was our very first ever AMS pharmacist at Royal Melbourne Hospital, who has just been awarded an NHMRC fellowship for her PhD. So I would like to have a round of applause for this amazing. Oh, yes, and where is Courtney? She's not here. So Courtney, the person who's not here, who had little baby Max, who was very sad to miss the day, is of course Courtney Urano, who is just like a stalwart in our department, our postdoc, who she does so much for all of us. And, you know, a lot of this, she actually initiated a lot of the organisation early in the year. I'd also specifically like to thank our incredible speakers, actually. So particularly Kristen and Satwik. Oh, with the next slide. Oh, here we go. There you go. So some of them are here, and we have got a little gift for you, which we'll provide, we'll give to you after we finish. And thank you so much, especially Lisa, who's come down from Queensland. And, you know, for those of you in the session today, she is a master in running workshops. I have been in so many different workshops with you, all different sorts of world cafes and this and that. And recently we're in Adelaide at the CRC Safe Work. She commandeered a room of like 200 people and had them like singing. So thank you so much. Kylie McIntosh, you've been such a great supporter of our team, our group for such a long time. You've also, you know, been, you know, part of the furniture now in Victoria. And we do hope, Victoria is challenging, you know, we've, how many networks? 76 networks. We all work in our little silos, but I hope that this event today, you know, you realise that we can actually work together. We are openly embracing your collaboration with us and our interstate colleagues as well. I was talking to a couple of pharmacists from the Austin. We have a lot of data available, particularly in the NAPS platform that we work with our medical students, pharmacists, to actually publish and look at the data. So please feel free. We do have a formal process of data release. It's ethically approved, and we're very happy to support projects. Narelle is not here, but you will agree that her presentation around bacteria of critical importance was, you know, really grounding to see what we face, but also what our international colleagues face. And I'm not going to brag here, but I have got a sabbatical in Italy next year, and I'm going to be spending some time with Evelina Taccanelli. If anyone saw her last year, she was a Forbes Fellow. And it actually be the first time for me to observe what it's like doing stewardship and ID in a country with high levels of antimicrobial resistance, and actually see firsthand the challenges that they have. And they're doing some incredibly innovative work with artificial intelligence to predict resistance. Jason, where are you? Is he here? Great talk. Thank you. And I think Jason is a great example. First of all, he doesn't sleep. So let's just say, he used to run on 4 hours sleep a night. He did the big rookie error. So his big rookie error when he was a PhD fellow, and he did his first clinical trial, and he had this information sheet for his patients. Guess what he did? He put his own mobile number on the bottom of it. So he had like 1,000, and I bet they're still calling you, right? Yeah, they're still calling you, right? Don't ever do that. Never put your own mobile number. Kirsten, where's Kirsten? Thank you. I have to say one of the great joys of NCAS has actually been working with our veterinary colleagues. They are absolutely extraordinary. You know, they do amazing things. They've also got great connections internationally. And, you know, a lot of what you're doing is really nationally leading and really driving the conversation because, you know, when we started, there really wasn't any, there just was no veterinary AMS. Ree, where are you? There you are. So Ree, again, an absolute joy to have you in our team. And Ree, of course, is juggling. How many emails have you sent out in the last few days, Redcat? Hundreds? A few hundred. So, you know, we're in the midst of doing our international Delphi survey. You know, we've done a few of them over the years. They are, you know, time consuming, very rewarding. And she has really brought together people from all over the country and internationally. And there's been a really good response, I think. Laura, are you here? Laura's gone. Laura Hardefeldt, again, an absolute incredible, another equine vet, and who has been really leading a lot of it, a lot of our, particularly with the Comet program. Misha, where are you? Amazing. So one of the takeaways from today, I think, you know, that measure of health services research success is to actually show that you can scale. So Jason's work in allergy, just from the humble beginnings of chasing patients around Peter Mac and delabeling them, through to an international network, developing digital applications, simplifying it down, demystifying, and also bringing allergy delabeling out of the immunology into ID and stewardship is really actually groundbreaking, and I think we should recognise that, and also the emerging roles of even consumers with self-assessing their allergies and empowering the consumers is a really emerging area, which I think we could take away stewardship-wise. And then Lisa Guccione, where are you? So I have an immense pleasure having Lisa in my team over at Peter Mac, actually, because I have a health services research implementation science centre over there. And so Lisa, everyone has said to me how fantastic your talk was, because I think it is actually really important to demystify what we're talking about here. And it is something that everyone can contribute to. So again, as part of our new CRE, again, we'll be deep diving into methodologies and helping some of you interested to learn how to use these frameworks, and also looking at the human factors piece as well, which we didn't focus on too much today, but it's equally important. Again, thank you for everyone.